Governance wing of the Gravity Project. Welcome to our December 10th call. We have probably an abbreviated meeting just because I think at Gravity we're taking a breath as we do two things, kind of reflect on the intensity of the ICD-10 submission and prepare for the Connectathon in just a little bit. So welcome to the meeting, and thank you for coming. And next slide, please. Again, just thanks for being here. We always do mute all of our members upon entry. And we ask that you remain muted to avoid background noise. The call is always recorded. So if we have a new member, welcome to the group, who just posted in the chat asking if the meeting notes will be on the Confluence page. So not only the meeting notes, but the full recording is always available there after the call. We actively work the chat field, so please send any chat messages to everybody. And I will be integrating comments from the chat as we move forward in the call. Precious, does that answer your question? I'm hoping so. Wonderful, yes. So this is just our standard antitrust practices slide, just that we always present at the beginning of each call. Next slide, please. If you've not already done so, we invite everybody to officially join the project at the Confluence. You can find the link, again, any single link that we suggest within the presentation, we try to reference within the chat. So for those individuals who want to concurrently follow the links, they can do so within the chat field. So if you want to join, there's a link to do that. If you want to check whether you've already joined or if anyone from your organization has joined, you can review existing membership at this link. And then the Confluence remains a vast amount of information on past, present, and future initiatives, on the different domains, on the team, on related projects. So you can always find just any information you could dream of finding regarding Gravity at the Confluence. Next slide, please. A nod to our really just impressive and amazing founders, the grants we've received, and all of the intense in-kind support. So much of what we do at Gravity is involved in the heavy lift of individuals and organizations that donate their time. So just thanks again, special kind of like end of 2020 thank you to that team of folk. Next slide, please. We very gratefully lean on the support of our financial funders. So if you or your organization would wish to look into becoming a donating organization, you can always email the Gravity Project. And again, the Confluence has information on everything we do. So there is a specific Gravity Project sponsors page on the Confluence as well. Next slide, please. We do want to formally welcome and everyone to the kind of the working group that for the Fire IG. That occurs on Wednesdays from 3 to 4 Eastern Time. And you can see the calendar for all HL7 meetings at the link. This is where really elements of the technical build for our implementation guide are worked through. This is a meeting that Bob Dieterle, the technical director, runs. You know, everything from questions of consent to questions of capacity to technical elements and syntax. This is all addressed in that meeting. So kind of the brass tacks of the Fire IG happens in these calls from Wednesday from 3 to 4. So please send any individuals in your organization who want to participate in that work to those meetings so that we can help shape the IG together. Next slide, please. Last call for this is the last time you'll see this slide. The Administration for Community Living Challenge Grant is accepting applications through December 14th, next week. We've talked about this challenge grant quite a bit over the course of our year. You can find the details and learn more about grant requirements at the 2 links that are posted right there. Oh, John Manning saying, I thought the deadline was extended to January 6th. So Evelyn, do you know anything about that?
No, I don't. We just met with ACL. If it is on the website, then they have, but they've received quite a few. But I'll double check and update it. Thank you.
Yeah, and we were just in a meeting with Kelly Cronin, so it's very apropos. Next slide, please. We mentioned this a couple minutes ago, but the Connectathon occurs on January 13th to 15th. The Gravity team is, of course, leading the SDOHCC Connectathon track. That is our track. And the focus of this Connectathon is the exchange and update interventions and exchange of observations, conditions, and goals. You can see the Connectathon track page at the first link. We really want to encourage as members of our community to join the Connectathon. There is a cost, so we do recognize that there's some kind of the cost for participating, but please do participate if you can. And then the general HL7 Fire Connectathon page is that last link there.
Sarah, sorry, can I just chime in?
Yes, please.
To let the community know that we actually will have our formal orientation session next Wednesday. As part of the previous slide that shows our fire IG calls, we meet 3 to 4 p.m. Eastern Standard Time with the link where our dial-in is. But our official orientation session to the Connectathon is next Wednesday as part of that call. We encourage you, if you just even want to know what a Connectathon is, what will be tested, information regarding overall the Connectathon and what the technical team has planned to test, please join us next Wednesday. Thank you.
All right. Next slide, please. So this is one, I'm just going to try, Evelyn, do you want to take this slide?
Oh, sure. Yes, thank you. Our colleagues at NCQA have an opportunity available for new fellowship next year. NCQA has been also very active in the Gravity project, and they currently sit on our strategic advisory committee. So this is just for all you to know that there is this fellowship available for next year, and we just want to encourage you to apply. Thank you.
All right. We're very, very grateful for all of our collaborators in this ecosystem who are part of the Gravity family, and it's NCQA included. Next slide, please. All right. So this still says new Evelyn, but at this point, I'm going to talk about the Gravity roadmap and upcoming domains and go through the schedule. Mark will briefly come in then and talk about the status of the Gravity USCDI submission, including letters of support. I am then going to go into the amazing work and just detail the submission that we presented to NCHS for ICD 10CM and opportunities for the community for engagement in that work. We're going to be talking about a few updates on some general work regarding goals and interventions, and then be closing with community homework and next steps. Again, as always, just use the WebEx chat feature to field anything into the community conversation, and I will try to make sure we address it. Next slide, please. So here is our Gravity roadmap. Slight changes, again, from the last time we presented it, because you can see transportation and financial strain and demographics kind of extending into the fourth quarter of 2021. You see those domains of social isolation, stress, and interpersonal violence kicking off at the first quarter 2021. And then again, I've gone and kind of put a place in the sand for the neighborhood and community domains that we were talking about being necessary work in 2021. And so I love that those who've been on past calls are aware that I've been mentioning a need to extend those timelines for some time, and there Carrie is noting approval that we finally adjusted the calendar. Thanks all. And then I do want to mention we have a kind of an infinity diagram for the Gravity work, the interconnectedness of the terminology work and the technical Everything we do at the Gravity Project is all intertwined. So at the same time, we're working in terminology. Of course, as you just heard, we're getting ready for the Connectathon and trying to get our IG ready for ballot, and that's all happening concurrently. And then also working with our federal partners and HL7 on planning for the pilots in the spring of 2021. With the roadmap, can we also incrementally increment SDOH in 2021? So I'm trying to understand what the question will be. So if you can imagine, many of these bars in 2021 will be uh, uh, basically fractionated out into different domains. So we kind of create space in the sand, and then as the SMEs come on board, we take shape of the different domains. For example, interpersonal violence represents a few subdomains that will get broken out into different domains once with the collaboration of our subject matter experts. That happened very distinctly with housing in 2020. And certainly neighborhood and community, there's a lot in there. I just put that there to kind of make space for it. So I think that might be what I hear as an answer. And if Doug, if that was not the question you're asking, I'm sorry. Did that answer your question? Wonderful. And again, we collectively Hi, Lucy.
Hello.
Hi.
Could you just clarify interpersonal violence? Is this any violence starting with homicides on the street by strangers and then moving into the family between adults on children, or interpersonal violence seems, maybe you could just define what you mean by that.
Yeah, absolutely. So this is a bucket that we're specifically being asked, according to our work prior, to focus on issues of elder abuse and intimate partner violence, not focusing on child abuse at this time. I think the reason why we're calling it interpersonal violence is that that is the general bucket that contains both of those subconcepts. We're certainly not going to address every single concept in that greater bucket.
Thank you.
Yeah, sorry for the lack of clarity, but we're trying to correctly name kind of macro folders for this work while we carve out elements underneath it.
So this is elder and domestic, but not child abuse, and certainly not community level violence.
We had not entered to do that, but we did end up talking about elements of neighborhood safety. We've brought that up as part of our neighborhood and community work in that meta bucket that you can see in the summer.
Okay.
Because neighborhood safety is one of the, again, if we think about the kind of the concentric rings
Yes.
of how, yeah. So that work we conceptualized as occurring as an extension of housing.
Housing.
Really.
Right.
Yeah. And occurring in the summer of 2021.
Just one very detailed question. Interpersonal violence, would that include screening for weapons in the home? And if so, loaded, locked, like that?
So that is not a concept that's currently included in the meta definition of interpersonal violence as defined by the World Health Organization. So presence of guns is not the same thing as personal history of experiencing violence. It might be a risk factor for blank, right? But it could be an extension, like you could imagine screening for guns being an extension of identification of histories of interpersonal violence with an individual. The reason why interpersonal violence is here is largely driven by its inclusion in the Accountable Health Communities tool. We know
I'm sorry, which health community?
The Accountable Health Communities tool, the HARC tool, and the HITS tool are two tools that have been used in national pilots regarding social risk identification. So it seemed important to include this in our initial work.
Okay, well, I'll just say when we get to this subject, I will certainly speak up on the grounds that we have the potential to move beyond WHO definitions, which probably take a decade to materialize and won't change for another decade. So thank you.
Yes, thank you, Lucy, as always. Any other questions on the calendar before we move forward? All right. And okay, next slide, please. So we took some time to try to get a schedule of activities to carry us into February, as we were kind of locked into our ICD-10 submission. So here we are right now, really kind of focusing on reviewing the ICD-10 diagnosis and the role of the community, and really talking about the steps we have to take to finish the data sets for specifically inadequate housing, transportation insecurity, and financial strain, so that we can vote on the elements of goals and interventions that have yet to be defined. You can see we're kind of taking a pause on education and veteran status, because we really want to make sure we get some of the data sets that have been extended through the fall complete. The 12/24 meeting is canceled because of the holiday. And then we hope to be moving forward through some of the last bits of inadequate housing, just getting them set, and then reviewing and voting on transportation insecurity and financial strain in time for February 2nd, in order to have a clean slate to pick up those the social isolation, stress, and interpersonal we were talking about earlier. Really trying to make sure that we finish a few of our elements well with intent before we add on more to the pot. Any questions? All right, next slide, please. I believe this is the infinity wheel I mentioned earlier, the intersection of the terminology work and technical work. Next slide, please. This is the logic we use to define where we are in our build, which is largely, we're in build and identify right now across most of our domains. Next slide. Any questions on the intro and orientation to the calendar? All right. I think I pass it off to Mark. All right, thanks.
Next slide, please. So this is just a quick update on the status of the tremendous work that the Gravity community is also carrying forward to try to get the domains that that you all have been working on and Sarah was just discussing into the US Core Data for Interoperability, which is a set of structured data that is carried across electronic health information exchange and would fit into the set that the Office of the National Coordinator has defined. So the as I think I briefed you before, we did submit, thanks, and sort of collectively representing your work. ONC did list that as a level 2, which is the highest level they can, meaning it's the benefits are there. It's been being used extensively. And really the new update for today is to note the tremendous numbers of letters of support that have already gone in, and more are coming. So you see a good list there at the bottom of your screen. We know that these letters are making a difference. We are talking with ONC. We know they have not yet made a decision about what's going out in the draft version 2 that it will be releasing this coming January. But in those discussions, they have been tracking each and every letter that is coming in, and they've said that it makes a difference. So, in addition to sort of updating and saying thank you so much to those who have written letters, consider this also an invitation to anybody else who wants to write a letter that please do, and it will make a difference. It will show the support of the Gravity community across the nation. And we can skip over the next few slides because I think that is just update of what people have seen already.
I have a question. This is Vijay. Is this going to be accessible by the patient access API, the one that's been developed with CMS interoperability?
So the way that would work, the answer is yes, at the point that the data has been integrated by the provider into the provider's electronic health record and is a part of the patient record. And I'm saying it that way because ONC merely listing it as an element in version 2 of the USCDI does not yet bring an individual's real data into a particular clinical setting. That's the next step that has to happen. At that point, yes, absolutely. They will be able to have access through the patient-facing API.
Okay, thank you.
And I'm seeing Lucy's question. Yes, letters can get into the, you can submit letters now. The deadline, we have been talking about not a hard deadline, but the functional importance of getting letters in as quickly as possible to influence ONC's thinking. Because if you think about this, they're coming out with their draft to the public in January. That means they've got to back up and make decisions and get those decisions cleared. So now's the time. It's not a formal deadline, but as soon as you can, please. I see also Alliance for Nursing Informatics. Thank you so much. I'm going to type my email into the chat and ask that you send that to me so that I can track and make sure that it actually is listed on the website. Have I caught everybody's questions, Sarah? I think Sarah's on mute.
Oh, sorry. I thought you were, I think we're good to go. I don't hear any other questions.
I don't see any either.
I want to say a specific thank you to Susan Hall, because those are my people. Yay for nursing informatics, says this nursing informaticist. All right. So one more question. Where do you submit the letter electronically, Mark?
I will drop a link into the chat box. You scroll down to the bottom of that page and you will see an indication to upload comments. So it's not going to appear at the top of the page. You go down to the bottom, you will see the words upload.
All right. Thank you so much, Mark. Mark is an amazing steward driving this push forward for USCDI. We're very, very grateful.
Okay,
all right.
Just posted the web link.
Okay. Thank you, everyone. And again, any of these questions, there is a specific page on the Confluence for the USCDI submission as well. We do try to be transparent regarding all of our activities. The Confluence is large, but it is searchable. So,
Sarah?
Yeah?
May I answer one other question that I'm just seeing in the chat box?
Yes, please, of course.
If I'm pronouncing your name correctly, I hope so. Yes, there is a letter template. If you will email me at the email address in the chat box, I will get it right to you.
Thank you, Mark.
You're very welcome.
All right. Thank you so much. And again, feel free to pipe in comments throughout the conversation. We're always happy to circle back around. There's a lot of kind of end of the year, final quarter of 2020 reporting happening today in this meeting. I'm going to be continually thanking all of you all as well. It was a remarkable year. Everyone was very kind to build in a kind of a grace-taking moment in our executive committee meeting today, but I'm going to be doing that throughout. Very grateful for all of the Gravity community and this work. It really, you are why all of this is happening. So thank you so much. Next slide, please.
Sarah?
Hi, Lizzie, yes?
I would just say that the Gravity work really has become the baseline for everybody talking about how to address improving response to COVID. So it was incredibly timely that we got started way before COVID. And now that we're into COVID and people want to understand how to deal with homeless people who are positive, where we really, I just want to say how timely it was and thank you for everything that you and your colleagues have done, because it really slotted into a national imperative.
Yeah, and I do want to give specific thank yous to our colleagues at WellSky and the HMIS work group we had, which was very timely. We kicked that off in February actually, And then once we had kind of pressing use cases all around us, there were some pretty amazing instant interoperable outcomes from that work group, and just grateful for the community and grateful for you, Lucy. Next slide, please. All right, so just wanted to go through some of the definition updates. I think there's one typo on this slide as I tried to marry like all the different pages and emails we have. So, but next slide, please. This is a note. You actually just saw me mention them a couple minutes ago, but this is a note to our meta kind of subject matter expert slide. All of these individuals are donating their time. Oh, Gabe, hi. WellSky, our friend Gabe from WellSky just piped in the chat, and I gave him a kudos. And so definitely very thankful for Gabe and WellSky's involvement early. It was a pretty remarkable group. So subject matter experts for housing, we have individuals across the ecosystem in HUD and HMIS, and research, transition and security. Again, we have research individuals, policy experts, and then of course, Jennifer from Lyft. Financial insecurity, we have our clinical experts in the nationally recognized Dr. Shigadans and Dr. Jeffrey Colvin. All individuals donating their time, many hours per week toward this initiative for over the course of a year. Incredibly grateful. Next slide, please. So transportation insecurity, this is a little bit in progress. I think there's one update that I could not find in time for this slide. I hope that the SMEs will correct me in our meeting right after this call. But we are integrating our synthesis definition for transportation insecurity. This becomes incredibly important as we consider building into SNOMED CT and developing some of the computable pathways in our implementation guide. Next slide, please. And then I did want to kind of pause specifically here because this is actually quite important and it ties into our ICD-10 submission. So our working definitions of financial strain and material hardship. So financial strain covering a state of being where a person has difficulty feeling fully meeting current or ongoing financial obligations or does not feel secure in their financial future. This is important because it's an experience of financial difficulty that's independent of income status, according to the federal poverty guidelines. This is important because this is what the literature looks to. And then developing a concept for material hardship, which is specifically the lack of specific social perceived basic physical necessities, lacking something that is standard that are required for health. And you'll see these definitions get carried out into our ICD-10 submission. Again, very huge thanks to our colleagues at AHIMA. I see Donna was on the call, and the financial strain subject matter experts for pulling this together. There's a lot of opportunities in the material hardship diagnosis that we'll see shortly. Next slide, please. All right, I'm now going to spend a few minutes just walking everyone through, which was kind of a fire hydrant approach to diagnoses that you collectively contributed to that allowed us to submit a pretty impressive body of work to NCHS in time for the deadline. And then we'll be talking about next steps for the community, because similarly to USCDI, we need your help. And Lucy, yes, it does. So we'll detail that in a couple seconds. And there's a really wonderful opportunity there. Yeah. Next slide, please. So call out. Thankful for the invested effort of our subject matter experts, our coding colleagues, and again, specific thank you to our friends at AHIMA, Donna Rugg and Kathy Gianangelo. Met with us weekly and for the last 6 weeks or almost 2 months in order to get that submission looking as tidy and correct as it possibly could be. We did get some help from coding experts at AHA as well. Incredible investment from our executive committee members, and of course, all of you. Just incredibly grateful. It's about 1.5 years of work. So very grateful for everybody's help. Next slide, please. So I post this here. There will be a link in the chat, and there's a place on the Confluence to review the submission. And I feel like it's important to note that not everyone will go there, but I wanted everyone to see the labor that went into the submission, because it's all of your labor. So there's a first page that details the background of the project and the why. There's another whole page that details our approach to ICDM, which includes perspective of on-the-ground workers in order to triage resources to those most in need, including anticipation of analyzing the effects of interventions to allow for medical social care integration research. That's part of our use cases. A second approach was anticipating the use of claims data to predict person-level risk within value-based healthcare and risk adjustment, so that the risk in the literature was always part of our perspective in our build, as you'll remember. And then third, to align with development and dissemination of national social risk quality metrics. We've already worked with individuals in order to build the food insecurity quality measure, and are working forward with individuals at NQF to align with planning for transportation and housing insecurity quality measures. And as we are aware, we did integrate coding to allow for measurement of Healthy People 2030 objectives as well. Oh, that's nice. Lucy's name dropping the blog that I wrote with Dr. Gottlieb on SDOH and E&M coding. And we'll try to get that in the link as well. Thank you, Lucy. The reason why I'm just showing this here is this is important to know. This is why we're making the case, and for letter writing, some of these things that are in this text might be helpful when you're making the case to NCHS about why this is important. Next slide, please. I then wanted to detail very carefully, and this is all should be familiar to you all. What we did in this submission is we go domain by domain and talk about the why, right? So the conversations we've been having in our collective over the course of the last year and a half about why this and why not that, and the case for why and the evidence for why. Every single domain gets a little call out. So education less than a high school degree, homelessness, housing instability, food insecurity, transportation insecurity, financial insecurity and material hardship, socioeconomic risk counseling, noncompliance and financial hardship and status. So there's a small rationale for each of these domains that represents the work we've done together. I want to specifically call out as well what you can see here in, again, you can see this much better as we go into, if you were to expand it, but I really felt like it was important to share this collectively. We are advocating for the return of a category in ICD-10 that was not included in ICD-10-CM. This is a category of problems related to physical environment. You can see this on the bottom right side there, so what would be page 4 of the submission. This came out of our work in trying to develop the food insecurity codes. We realized the inadequate drinking water supply really is best suited in that physical environment root category. And that would allow us to build our 2021 neighborhood and community concepts that we already have on our docket. So and this aligns with international ICD-10, which has the Z58 problems related to physical environment category. So this is an incredibly significant change, and it's going to be a big lift. So if any individual wanted to make the case why social determinants often involve social risk or community risk beyond the person, it's a really important thing to replace for us to do our work well now and do our work well in 2021. So I know this text is very small, and again, I'm sorry, I felt like it was important to show it. The whole submission as it stands is available on the Confluence on a separate page, including information about how to write a letter of support. So the things I wanted to highlight here are the domain by domain rationale and the return of this Z58 problems related to physical environment category that will allow us to build these kind of neighborhood and community concepts in the correct place. Any thoughts or comments on that before you move forward?
Sarah,
Is there-
who decides this? Who is the final authority on what gets included here?
Yeah, so we were going to talk about that in a bit, but I think it's actually really important now. So there's a committee called the ICD-10 Coordination and Maintenance Committee. It's a division of the National Center for Healthcare Statistics, and they have a meeting in March. And so they are very aware of our work. In fact, they have been very supportive of kind of routing the requests for social risk ICD through our work. But you know, one of our final slides in this section of the presentation will be asking for all of you to write letters in short order, similarly to USCDI, to have this be heard at the March meeting to get these codes into build. So if they go through and pass the March meeting, they will be live in use in the US ecosystem in October 2021. That is not very far away.
Be sure to email all of us the link to their meeting.
Yes, that. Oh, you mean for testifying live?
Yes.
Or you mean, yeah. So we'll send all of the links. So what we'll do from now until March is update the tab on the Confluence, which is the ICD-10 submission, with relevant information, links and information.
You know how I love that website. Thank you.
Yes. So Lolita's asking a question. Anyone who has a history of military service and is a veteran would be included in this. Again, our screening questions and answers are not U.S. service alone so far, so that you would qualify just by having a history of service at all. So any other questions on the return of the Z58 series, this problems related to physical environment? Yes, a good letter template and outreach to pop health directors may be helpful. Okay, great, that's a return. I did include, you'll see these later, really some talking points, and so we can talk about those in a little bit, but we also are happy to work on letter templates. I think that one of the things that is tricky about letter templates is the template might be specific to the stakeholder, and there's many, right? So I think we're here to assist, but depending on the stakeholder that's writing and the perspective they're writing from, the argument might be a little bit different, but we're happy to help. Next slide, please.
Sarah, just let me say, to encourage people to send letters of support. You can imagine being a bureaucrat having to read thousands of letters of support. You're only going to get even 2 seconds if you, at least in the first paragraph, say something different from a template. Otherwise, it just, goes in one ear and out the other. So templates are very helpful to start your process of what to say, but please don't just copy and paste and sign your name. Thank you.
Toward that end is partly why we included, so I think probably we can do is we can imagine both. So what I'll do is Miriam, what I'm going to show you once we get there is what we collated on the Confluence to assist with letter development. And then maybe we can do is augment that so it's helpful. So this page here, really it's here to detail the fact that we didn't just work on the codes themselves. Oh, this is a repeat, sorry, there's a copy. We also developed inclusion terms. So next slide, please. This is a better version. So you can see, for example, and this ties into what we were talking earlier. So under financial insecurity, not elsewhere classified, and material hardship, not elsewhere classified, you can see the concepts that are equivalent or would roll up into that concept. Again, huge thanks to Kathy Gianangelo and Donna Rugg and Linda Hyde. Really just huge thanks to Linda Hyde, because Linda my colleague in this work in Gravity, just did immense effort on this project, and I can't say enough about her. But you can see the concepts that might be equivalent to it in a history documentation are included in the submission. This is important for things like natural language processing, or just for a human review of a history and document, or even just trying to translate the natural language of individuals into a diagnostic code. These inclusion terms are really helpful when it comes to coding, and they're also helpful for us in the clinical practice in order to figure out what we mean when we say financial insecurity. The definitions relate to these concepts, of course, as well. So, are there any concepts for transportation included besides these? So, right now, this covers all of the elements. Well, on the previous page, if you go back again, I think I had to do the one I'm worried about is that I didn't. Oh, here we go. So this is you see two of the same page. This is what happens when Sarah makes slides late at night. But you can see transportation includes everything from excessive transportation time, inaccessible transportation, inadequate transportation. Then next slide. Lack of transportation, unaffordable transportation, unreliable transportation, and unsafe transportation. So Gregory, does that answer your question? So that those are pretty much the domains of individually experienced transportation insecurity. You mean, what about type of transportation? So maybe you can unplug and help us understand what you mean.
Sure. So can you hear me?
Yes, I can.
Yeah, thank you. So I'm Greg Alexander, so I'm new to this group, but I'm so glad to be part of it. I heard presentations at Amy and decided to join.
Oh, welcome.
So I work a lot in the long-term care space where transportation is a huge issue, getting residents from long-term care back and forth from different locations. And they may take multiple types of transportation, like they may take EMS, they may take cabs, they may take Ubers, they may take family, there's many different types of transportations. And also there are different types of like a transportation arrangement may involve a wheelchair, it may involve a walker, it may involve a cane, it may involve sort of things that need to be thought about in types of transportation that will have effects on people's access to care if they don't have the right kinds of transportation available. So type of transportation is super important.
Exactly. So that ties into a conversation we've had at other times. So I have two answers for you. So, and thank you for bringing it up, because our community is fluid. So individuals come to some meetings and not all. So it's really important to bring this concept up. I did a quick review to see if any of my transportation SMEs were on the call. And if anyone is here that I'm missing, please pipe up. But I'm going to try to do my best to answer in two different ways. So first of all, one of the things that Gravity has identified early is that there are critical bits of information that aren't the same thing as a screening to end up with a diagnosis. And so for instance, like this came up very intently, and again, Gabe's on the call, in our work with HMIS, like qualifications for HUD programs and HMIS chronic homelessness specifications is not the same thing as asking whether an individual is homeless. So, and similarly with the actual mode of transportation, our work with subject matter experts, we identified that defining a mode of transportation doesn't necessarily state that a person is transportation insecure, but that information is critical. So one of the things we do in Gravity is where we basically create like sub work, where we develop screening questions, like panels of questions and answers that are critical for care coordination and meeting the needs of patients, but aren't the same thing as this is a question that comes up with an answer of transportation insecure, yes or no. So that work is happening, and luckily our transportation SMEs, as our SMEs across the ecosystems, are experts at figuring out what those questions and answers are, like the next things you need to know to have robust information on the patient. And the other thing I'm going to say is a lot of those elements will also come up in our interventions. So what Gravity works on as well is developing kind of a robust taxonomy of programs and development. Like what are the programs and professions that are critical for addressing the need? A lot of those types of information we start with in kind of like granular buckets and then sort them into parent concepts that are applicable across the national ecosystem. So you'll see many of those elements you're talking about in two different ways, hopefully by the time we're done. One in a supplemental panel that you could utilize if you were working with a care coordinator or a community health worker in order to identify what the patient's currently using. And then another, which would be involved in what to connect the patient to in order to meet their needs. Is that helpful? Maybe that was more.
Yes, thank you. Sorry, I went back on mute. Yeah, that is, and very important to think about in the context of different, across the continuum of care.
Yeah. Hopefully by developing these encoded panels of informations of qualification, we call them basically eligibility and enrollment panels, like what programs are people eligible for and what programs are they enrolled in. This can actually allow us to address the needs we're identifying. So that's the dream. But it's like related to these diagnoses, outcomes of transportation insecurity, but not exactly the same thing. So that's why you don't see them here. Yes, and yes, there's lots of really wonderful chat that I'm not able to keep up with. So they're talking about mode is captured in the health record to address the assessed problem of lack of transportation. A referral ambulance transport might be the intervention. Exactly. There's a lot of these conversations we're having with our subject matter experts. I'm just going to state very plainly that if you have an idea of a type of transportation or a program or anything that you feel like is important, one of the things that's happened is, as like in this phase of our project, there aren't as many submissions from just any member. So we've started to do little work groups to try to drum up submissions of concepts in programs. But if you have an idea of, I think this needs to be a program within this or a resource, just email Gravity and get a conversation going so we can make sure that thought's included in our data set. Next slide, please. All right, so the next step for the submission review is the March 10th ICD-10-CM Coordination and Maintenance Committee meeting. Again, here is the email, and this email is on the Confluence page that there's a link for right now. We really are hoping to get these emails in with it by the end of January, just because this submission has been in various forms, either at a committee meeting before or not heard at a committee meeting. And we want to make sure it is heard. So these applications are really to stress the point that not only are these codes necessary, but these codes are timely and it needs to be heard in March. And then I'm just here, we have, there we go. So Eric is Eric's piping in from his vast history in the homelessness sector. Chronic homeless, is this probably to my utilization of the HMIS specifications in my conversation? So one of the things that's difficult is, and maybe Eric, you and I, we can have a conversation now, but maybe we can try to save it for the end just for time, is separating housing instability from homelessness. And we have, we can always bring back some of our conversations about chronic homelessness and HMIS. Maybe we should have a revisiting of that subgroup in order to make sure we're addressing that use case. Next slide, please. These are just key points, again, to highlight in the letter. So first of all, the broad stakeholder representation. of the Gravity Project. Another is that risk-based approach that we discussed as detailed in the rationale, and I discussed that earlier. Again, all these prompts are on the Confluence page. And then next slide, please. Other points that might be important to highlight, just the pressing use case right now. So discharging COVID positive individuals experiencing homelessness, and then considering the economic outcomes basically in these twin crises of the pandemic and the economic strain within the US community, including increasing food insecurity rates, increasing risk of eviction and housing instability, and increasing financial strain. Again, here's the link to the Confluence page. I include resources to back up all of these claims on the page as well. And what I'm hearing is some kind of template might be helpful as well. And so maybe we'll create some kind of template text in order to utilize for the letter. And again, I want to state that the rationale as part of that ICD-10 submission is an excellent letter minor as well. There's a lot of text in there that can be borrowed and utilized in your letters as you build your letters of support. Next slide, please. Any other thoughts or comments? I do want to try to save time if we can revisit Eric's comment in order to talk about HMIS and chronic homelessness, and then our approach at the end if we have time. We do have one more section to get through before the end of the meeting, though. All right, next slide, please. I wanted to revisit some of the work we're talking, well, actually, before we go on, thank you everybody for your work on the ICD-10 submission. It was an amazing lift, very grateful. It's really actually just so impressive and just very grateful for you all. So now to segue briefly, just because of time, and here I thought this meeting was going to be short. We always have to take time talking. As mentioned early in the last quarter of 2020, one of the things we recognized was that there was a need to kind of get some consensus on goals across the ecosystem of different interoperability initiatives and different social initiatives and different terminology initiatives, because we recognized that we were stating what goals were in different ways. One of the things we're doing is meeting with the HL7 patient care work group, but you are the anchor of pretty much everything we do. And so I wanted to bring something here that I've talked briefly about before. So one of the things we're exploring in our work on goals is the relationship between goals and protective factors. So anyone familiar with social determinant literature understands that basically social determinants are not all risk. You have social risk, which is concerning for associations with poor outcomes. And then you have protective factors or social protective factors, which insulate and foster wellness. So the two of them weigh on an individual or influence an individual's outcomes. So essentially, an individual is never the sum of their risk alone. And so if a goal is a desired state, as it is phrased in the work of terminology and interoperability, one of the things we've been wondering is it appropriate to build protective factors for use for global goal setting? So what is the possible relationship between protective factors and the desired statements of goals? That seems probably all abstract, so I'm going to take you to the next slide. This would be an example of how that might play out, right, regarding specifically transportation insecurity. So we really are just trying to explore this ecosystem because we've identified for a very long time a need to make sure we're considering protective factors in our work, because again, we do not want to just identify risk from a person-centered perspective. The work of care planning and care coordination and patient-centered medical home recognize identifying protective factors as a pretty crucial part of ascertaining a patient's goal for their own wellness. And so you could see or hypothesize that if we played this out with transportation insecurity, you can see there's the meta domain of transportation insecurity, and then these should look familiar because they're all of those different sub-concepts. So lack of transportation or inadequate transportation or unaffordable transportation or inaccessible transportation. And then one can imagine that there's mirroring protective factors on the other side, or mirroring at least positive elements of that, a positive domain. So if transportation insecurity is the meta risk, transportation security is its balance. And then there's all of these possible subdomains that balance out the other subdomains under transportation insecurity. Part of the reason, again, there's two different benefits possibly from this approach. One is that what we know from the literature is it's very difficult to move meta risk. So given that the security includes worry and stability, it's difficult. For instance, the literature of Craig Gunderson in food insecurity is very, very clear in this. Like, I might change an individual's depth of experience of food insecurity, but I am not likely to change prevalence because it's hard to change the worry of returning to the lack, right? So if stability is part of security, that's a difficult thing to change in the absence of major structural reform. So if we identify these kind of subdomains, you can imagine having action on a subdomain, like you might identify a safe way of transport for an individual who has unsafe transportation, or you might give somebody gas card vouchers who has unaffordable transportation. But you might not change whether they're like meta transportation secure. So this is not the only way we're thinking about approaching it. The reason why, again, we're kind of creating space for this in the conversation is a responsibility to consider protective factors as we do our build, and just a responsibility to consider that having action on micro elements might be more tenable for many of our individuals. So thoughts from the peanut gallery. We have Eric Hummel saying this is important in risk management. We look for the depth, not just does it cover the ground, but what is the safety net that catches the unanticipated vulnerabilities? Yes. And then Mary Ellen Rose is saying, if I understand protective factors correctly, I think this is a very good idea because knowing what the client has to help them is a very important factor in self-empowerment. Yeah, so that's part of what's behind this work. And I think part of it is wondering, if we know we have to build protective factor language anyway and terminology, can it be used in multiple ways? So instead of developing kind of a proliferation of terminology that has individual uses in the ecosystem, if we're building protective factor language, can it function in goal setting as well? Any other thoughts from the work, from the group?
Sarah, this is too.
Hi, yeah.
I just had a question, this is Lisa, about the difference between protective factors and outcome, the goals setting for each one of these. How are they different in terms of you assess the need and you have outcomes for that specific need that assessed? How does that relate to the protective factors? I'm assuming the protective factor seems like it's a measure, it's not a measure, it's an intervention for the need.
A protective, well, it could be framed as an intervention for a risk. It could be framed as the goal from the position of risk, right? You can imagine, one of the things we're imagining also is that from an outcomes perspective, we still want to build language for things that are more granular, like ambulation, walk 5 steps, or some of the LOINC panels you see in care planning and goal setting. But you almost can imagine the protective factors as the lighthouse beyond all of those things, kind of tying them together. These concepts of protective factors also could be included in outcome setting for quality measurement, or within population health initiatives as well, if they were choosing to do so. Did that answer your question, or do you want to rephrase your question?
No, I think I just need to think about that a little bit. Thank you.
No, I know, and we're thinking about it together. So I do want to state, yeah.
Sarah, I wanted to say that maybe this is naive or old-fashioned of me, but my introduction to protective factors has always been about agency or connected to agency and resilience, optimism, faith, those personal attributes that could help to deal with things. And thinking about this, if we start listing in a code protective factors that the provider thinks the patient or the client really could take advantage of or should take advantage of, and then they don't, that this could become a two-edged sword where somebody looking in aggregate starts blaming the victims for not taking advantage of what a middle-class provider considers affordable transportation. Or so I just want to wonder whether that comes into the thinking about protective factors now.
You're very good at identifying. This is what you do best. I think it's important to consider the risks of anything we do. In fact, that's part of our, our principles that we collectively identified, right? So I imagine these being at the way it currently happens with the protective factors in care planning or self-management work in patient-centered medical home, or even like utilization of things like Camden cards, is patient identified, right? And goal setting is by nature patient driven. I think judgment is something we want to be cognizant of and bias across the ecosystem. But I don't know if it's any more a risk with this kind of language than any other goal setting, like whether it be improve your A1C or weight loss, or I think it's just something we need to consider, and you're very good at raising that. As always, Lucy, just very, very grateful.
Well, I agree that almost any interaction between a provider and a patient or client could end up having attributes that make it look like the patient is not complying. But this conversation hasn't come up before. So protective factors, from my point of view, I don't know. Having a system identify protective factors for an individual, I really look forward to a lot more conversation about it, because instinctively it makes me uncomfortable.
I think we'll have to hold, as Brene Brown says, hold space for that, because I think it's important to consider like how we address that. I promise to, right? I do want to state that we imagine these things. I think there's a couple questions in the chat that tie back to that. One is Art was asking whether I'm trying to find the question. Are protective factors anticipated to be measurable items in SDOH screening or inferred from the absence of the need? So far, we have not we have not been comfortable in simply saying that a person doesn't have a need, that it's the antithesis is true. I think we'd have to take just from even a measurement perspective, like I think we're cautious to state that. And again, I think if we imagine this coming out of the work of goal setting, it's not just that the goal arrives the moment you screen a patient for a concern or diagnosis. The goal arrives through conversation with the person, right? That's the way all of our goals, concept, and terminology has been conceptualized before. So I would be incredibly cautious in simply assuming that the absence of saying, yes, I have this problem means, yes, I have this asset. Things to consider, especially as we consider how these are going to be operationalized. We have some wonderful folks from the patient care work group on the call today. I think I just want to make sure that we have all these questions in here. So, Art, did that answer your question? I think so, Art. I can't hear you, so I'm hoping.
Sorry. Yes. Thank you.
Yeah. Does that make sense?
Yes, Sarah. It's just that when I think about this, it'd be an enormous task to define all of these things being present. So it's going to have to be probably as a goal rather than to actually state these are attributes the patient has. But at some point, we're going to have to measure that we've made progress toward that, having somehow identified it as a need on that left-hand side. So, in the process, we'll want to somehow say that it's no longer a problem. And I guess that then means that we've achieved something on the right-hand side.
Yes, certainly. If we do move this to fruition, right, moving from unsafe transportation identified to safe transportation identified would resolve unsafe transportation in a technical way, one would imagine.
But it seems like it's being inferred by its absence on the screen that it's no longer a problem.
Yeah. I hear you.
But I like the focus on the goal. I think that's a good idea.
Other thoughts from again, I'm sure Laura, who's on the patient care work group is hearing all of this, which is very so. Any other thoughts before we go forward?
Yeah, hi, my name is Wendy Heaps. I work at CDC and I work on some transportation issues. And I haven't been expressed already. But what I wanted to say is that on this list of transportation, one thing that isn't really described is efficient transportation. For example, people in rural areas, especially who are relying on Medicaid support to cover transportation. Sometimes Medicaid will only cover the more circuitous routes to get to healthcare. So I'm just wondering how this is reflected on this list.
So we had conceptualized that as being part. So I'm a rural family nurse practitioner and do rural family med. So I hear you. 100%. That's my daily beat. So we had conceptualized that as being part of excessive transportation time within our, and this is not just a rural problem. Like some of our SMEs, for instance, had to took 2 hours to their primary care provider just because of insurance issues. But I actually couldn't singularly imagine the opposite of that, so I didn't put that in there. But that was part of, in our definition for transportation insecurity, I did think we used the word efficiency or something similar. Part of the problem, and this we can identify this as being similar to our work with food insecurity. And again, I'm sorry, we're hanging out. Sometimes we go to 5:30, so here we are extending past 5 o'clock. Sometimes what we do in our work here in the Gravity Project is identify domains within the like subdomains within the meta domain that don't currently have good screening questions or answers for them, right? So if we for instance, with food insecurity, we leaned heavily on the work of Dr. Coates from Tufts, who basically has kind of detailed all these elements of food insecurity, but only some of them do we regularly screen for in our food insecurity work. And this happens across our domains, as you can see. So for housing, transportation, we have screening questions and answers that get to some of the elements, but certainly there's a lot of work in tool development and measure development in order to get to some of these other domains.
I think that's a wonderful comment. And I'd like to stress that in light of COVID, it's not going to be just a rural problem. Like metropolitan transportation has crashed as a result of COVID. And who knows, that is crashing of demand for those services, and who knows when it's going to come back. So I just want to be sure that everybody understands that this is not just a rural issue in the current environment.
There's a lot. Thank you, Lucy. Yeah, so I'm just trying to go back up to far enough in the chat to understand. So there's a lot. So one of the questions, so Michelle saying, I would documenting a protective factor could be has reliable transportation, may prevent a provider from asking the question in the future. So this kind of ties into some of the questions that we've had, regarding how long these elements last for patients and timeliness, just from a truth and patient reflectiveness perspective. We've been talking about this from the risk-based perspective as well, like not having these elements remain in individuals' records forever because there's some truth possibly lost in that. So that would go there again. And then it seems definitely protective factors could include personal perspective and mindset, positivity, faith, hope. Certainly, and then there's also, social connectivity. There's the literature of protective factors is quite robust, and we will make sure. Again, I think part of it is that we'd imagined somehow that the work in protective factors was future work, right? Like that somehow it was in the parking lot, right? But one of the things that's coming up for this work in goal setting is that maybe actually some of the work of like at least asset statement and the roles that assets and protective factors have together, especially when we're considering care planning, we're naming the things that you have to lean on as part of that process. That maybe it's not actually future work and we can consider it now in light of our goal setting work. Marianne saying that the questions and answered by the patient and protective factors are also answered by the patient. Yes. And then Lisa saying, I'm wondering the same thing about assessment of protective factors and how that's demonstrated in clinical workflow. Typically, you're assessing for the need. I think that the part of what we're uncovering here is the moment we're talking about goal setting, and the need to identify goals was partly brought in because of our integration with other initiatives, such as our multiple chronic care plan initiative that Gravity is involved with, and other interoperability initiatives. Is in order to maintain a patient-centeredness, we can't forget about goal setting. And goal setting almost always includes, at least in my experience, assessment of assets. So for instance, I'm a patient-centered medical home, and when I'm doing self-management processes regarding my patient's chronic conditions, we identify goals, action plans, assets, and barriers. And that is all patient-driven. What is your meta goal? What are your steps toward that goal? What are the the assets you have, and what are the barriers you have? So all of this work is part of self-management, care planning, and this is partly why I brought up the Camden cards as well. It's the work of ecosystem assessment and social work. It happens, and it's almost always patient-driven. Any other questions before? First of all, thank you. I think there's a lot here to unpack. I don't think, if anyone has anything that I've missed in the chat that they feel like is important, because what we're hoping to do is what we just did, basically, is percolate these things with the community and then take them back and fold them in to our conversations we're having in order to try to figure out some kind of path forward.
Hey, Tara?
Yeah?
This is Carrie.
Hi.
Hey. So I'm trying to wrap my head around this a little bit. To me, this really seems like the work that community health centers do.
Yes. Carrie's like,
so jam. I agree with the people in the chat. I don't think these are one-to-one relationships. I think the work, kind of the process, is the risks are identified, and the way to fill the gap of those risks is through advocacy, not through patient action. And I don't know if I'm saying that well, but it seems to me like maybe I'm not sure what that means for coding and payment and everything, but it seems like that is more of a community action thing rather than something that goes in the patient level at a one-to-one relationship.
So Carrie, as always, that's actually, I think that's incredibly helpful, because I think, you know, it's not a pick yourself up by your bootstraps thing, right? It makes me think of, there's this really lovely documentary about West Virginia that just came out, and their food insecurity rates in the pandemic. So this is work we have to do. So it's not the same thing as, it's similar, but not the same, maybe the same thing as, you know, your A1C is out of range, right? And in that this is what you have to do to get there. But it mirrors the way we've talked about goals in our other, like within homelessness, safe shelter was one of the goals we defined in our homelessness work, right? It's not the individual's job to get to there alone, right? It's our work to help. So I think it's helpful to state that it's not, the action here is collective and collaborative, maybe even structural. It's not you person do this thing.
Yeah, I think structural is a good word to think about these in a way to think about these things.
Yeah, I think that's helpful. I think for also just it makes me think about Lucy's comments regarding, you know, almost blame, right? Like if the agency is collective and structural when it comes to these things, that definitely tempers possibly that risk, doesn't eliminate it. Nice emphasis structural.
Wouldn't it be incredible, Sarah, to start having coding for social interventions? We're talking about social determinants, and there's a great tendency to feel that if we identify social determinants, we will do better patient care, which is patient-centered and individual-focused. But the reality is that a lot of social determinants can only be fixed by, let's say, structural interventions, just to be very, very polite. Imagine if we could code for that. Imagine researchers discovering one of the unanticipated consequences of being able to code social determinants is to start underlining and quantifying just how much structural intervention would really be needed to fix anything. So I want to thank Carrie for bringing this up, and it does definitely reinforce the discomfort that I voiced earlier.
Yeah.
Lucy, that would be amazing for us to have and be able to advocate for our own patients with hard data that way. That would be, yeah.
That would be amazing, and sort of expanding the scope of what coding can say if you look at it right and do it right. And this collective or this collaborative would be a very appropriate voice to start that discussion.
Yeah, Lucy, and I almost feel like it's imperative once we start talking about, I mean, I can't imagine talking about this well within our concentric rings of risk model. Like if we start talking about community, 2021, building space for that, right? We have to really talk about what a community intervention would look like and how we define that. I can't imagine doing, I've been anticipating that as a requirement, really, what community interventions would look like. I think part of what we do, and again, I think the fact that we have folks from who are far wiser than I in tech is, one of the things Gravity's had to do from the get-go is kind of ask, the interoperability world to create new personas in things, because when we talk about social determinants, we start talking about things in different ways. So I think it's important to name that that's part of what we would have to do. Any other thought? This is a classic, delightful Gravity conversation on a Thursday evening. Asha, my friend Asha, is talking about the sector collaboration. Carrie's echoing housing and environment as well. Yeah, environmental context. This is Elizabeth Skillen. Marianne has a link I can't follow quite yet. Ruth is commenting about history of imagining protective factors. Yeah, see, that was part of the, classically, that was the balancing act or the seesaw that I had at the beginning. And Bill, hi, Bill. Certainly, neighborhood environment and neighborhood interventions are crucial when we think about food security as well. Thank you, Marianne. I would love to follow that link. So this is important. I think I have like one more slide I have to show you before we go. A lot to process and hold in my mind as we go forward. So next slide, please. I just wanted, is it okay to segue just so we can respect time? So I did want to give an update. So last time we met, we asked to have a little small working group to think specifically regarding the programs and professions that are crucial for all of our latter domains of transportation insecurity, financial strain, material hardship, education, employment, and veteran status, because our submissions, our data sets are slim in those areas. So we met on 11/20, and we do have a standard now email and program collection spreadsheet. Oh yeah, so John's asking for, he has not, we'll conclude that as I'll bring it back to the SME. I'll meet with the SMEs in 8 minutes. And so John, I'll bring that back. So we're hoping to, again, bring in all of those thoughts and comments from that program and intervention initiative by the end of, in a couple weeks. I know some of our colleagues were wanting a little bit of a longer timeline. I think the intent is to try to be able to present our findings by the time we gather again in early January, in order again to vote on those data sets by early February. So if individuals can try to send, again, these programs ideas, that's wonderful. If you want to help, send an email to gravityproject@amiadvisors.net, and we can just send back this canned email that I wrote with an Excel spreadsheet, and you can disseminate it across the ecosystem. Again, the idea is to really try to build out our programs. Again, we're building basically a working taxonomy of programs that we can build into US terminology for across all of our domains. When Carrie says early Jan's reasonable, thank you, Carrie. So Carrie is doing a lot of work with her group. If you need further information on this, just send us a call. Again, the work is to try to build out the intervention segment of our data sets across our latter domains. Next slide, please. I made a word cloud for Lucy. I don't know if she's still on here. So this is our initial transportation program brainstorm, including all of our programs that we came up with. I always try to make pretty things for Lucy Johns. And not as good at the house.
Thank you. I'm here. It's beautiful.
Next slide, please. Next, homework and next steps. All right. So there's a lot to do, submitting concepts for the different domains, again, especially focusing on interventions. Please send any thoughts regarding our goals conversation. And actually, when we meet again in early January, if anyone wants to come and participate in those calls from any of your areas of expertise, please just let us know. We'll get you involved. And then, oh, thank you, lovely. There's a lovely link here. And then again, as mentioned earlier, I think is there another slide? Next slide. So just I wanted to quickly highlight again before the close of our time, big things, big asks are the letters to USCDI. There is all the information on the slides that will be available to you. You can also email Mark. Also, big lift, these letters to NCHS. There's a page on the Confluence regarding it. It's been in the chat, it's in the program, in the presentation, and it's in, it's in the, you can email us and get it as well. And then just ping us again. So many things going on, the intervention development, the goals conversation, and just finally, I just want to offer a collective, what a year, 2020. What an amazing work we've done over the course of this year. I think we've really gelled as a community, and just so incredibly grateful for all of you, the virtual collective, and Gravity just remains very thankful for all of your participation. Any other thoughts before we close our meeting?
Can't imagine a better person to be creating this collaborative.
Ah, wow. Likewise, we co-create it. I'm very, very grateful for all of you. And I'll see you in 2021.
Happy holidays.
Happy holidays.
Bye, everyone. Thank you.
Bye.
Bye.
Good night.